We're really fortunate tonight to have Michelle O'Toole with us. She's the Regional Program Manager for the Office of Developmental Programs, otherwise known as ODP, of the Western region. Actually, I didn't know until I read this that you began your career as a DSP. You've worked as a behavioral specialist. You worked in the county MHID program for over a decade before joining ODP. Michelle's focus has been supporting people with co-occurring MHID diagnoses, transitioning individuals from institutional to community environments. Boy, I bet you have some stories there.
Couple.
Yeah, and developing capacity in the community to support individuals throughout the lifespan. Michelle served on the human rights committees at the state center to provider and county levels. She has a BS in psychology from the University of Scranton, and here we go, over 43 years of experience working with and on behalf of individuals with intellectual and developmental disabilities. So we have someone with us tonight that's got a very broad vision of where we've been, where we've come to, and maybe a little bit about the future. We're going to hear from her tonight, and I am really thrilled to hear her speak. And then feel free, she's here for good conversation. So this is our chance to really hear what's happening at the state level, and I'm turning it over to you.
So as Judy mentioned, I started out as a DSP, so a direct support professional, and actually turned me into becoming part of this community because I had been focused on neuropsychology prior to getting a job because I needed insurance like so many other people before I went back to grad school, which was a bust for me anyway. And loved the work. So I loved the work. And I was fortunate in 1980, the ICF, the intermediate care private programs were just kind of getting started. And so I really had the opportunity at that point to participate in a lot of development of, the stuff we were going to do and how were we going to keep busy all the time. And we came up with, one thing that we came up with was we went out and bought newspapers on Sunday because a lot of the folks that we were supporting really loved the bride section. So somebody accidentally came in with a newspaper, and one of the guys, Nick, he was so excited about the bride section. So we were able to turn that into something that we could do with everybody as opposed to having dead time. And it just started giving me a taste for just life. Just life is what people want. And for lifelong learning. Because, I still watch home improvement shows. I still, learn how to bake and watch all kinds of videos. And my daughter just got me 2 new books for Christmas that I've already tried out. So, those are really the 2 kind of driving forces when I think about the work that we do is, what do we all do every day? And how do we make that an opportunity to always be gaining new skills and even more important for the folks that we support who are so vulnerable. The more independent you are, the more you can do for yourself, whether it's putting your clothes in your drawer or taking care of the skills that you need to wash your hands even after the bathroom, the safer you are. Because you know what's okay and what's not okay. And if somebody's doing that for you all of the time and nobody's teaching you that, it's something you could do, you're at more risk. So those are kind of the things that I think about a lot when I'm doing the work. And then I also think a whole lot about families because we know that the vast majority of folks are supported by their families. They're not supported by residential programs. That's not where people are. And so I know that for a lot of you, moving into a model that allows for people to have their own places and be supported within it is something that you're, laser focused on, and I think you should be laser focused on it. Don't have the solution yet, but I'm really happy to be working with people to find it. So, just to give you an idea of where I'm coming from and what I'm thinking about. For ODP, the focus really is on children and families as one of our primary areas, and additionally, you'll see it's focused on quality, and particularly some of our quality within our supports coordination and residential services. So I'll talk a little bit about both those things. And I wanted to talk, if people read the November waiver amendments, so I know it's just a part of your life, right? But you can find them, that there's something that really, there's a new service, there's a couple new things in it, but I think of y'all, and certainly Tina and Judy, because I know that you were part of the idea of a family medical support assistant. And y'all presented that to Nancy Thaler some period of time ago, and it's in the waiver now. So that is just like something so exciting to me. We're working on trying to find providers. I know that that's, something that we have to do better at and we work at. But if you do look in, you'll see that family medical support assistant. And I think if you look back at the job description y'all gave us forever ago, it probably is a real close mimic. So really to help with those kinds of things that families are constantly doing that takes away from family time and relationship time of, coordinating supplies, making sure your supply closet is full, because if you don't have it, it's not going to work for you that day. You need all of those things for, vents and feeding tubes and, incontinence supplies or any other kind of medical supplies that you need. And who orders that stuff? You do. So how do we get that off the lap of the family? And, also helping with some appointments and coordinating and doing of all of that stuff. So I really highly suggest take a look at that service definition and, really kind of, and I can send it to Judy. It's in the, even if you go to the DHS website, you can just click on stuff, but I'll send the path. But you really can see parent advocacy when you read that service definition. And we're government, so everything's a little bit longer than anyone would like it. But that is solely parent advocacy right there, new service to be offered. Additionally, we have added a new eligibility criteria within the waivers, and that is for medically complex children. And so recognizing that the best place for a kiddo to learn, develop, and grow is within a family setting, whether it's a natural family or whether it's a recruited family. It's a lot better than large facility-based. Not that there's anything wrong with the people in larger facilities. They're all very dedicated to what they're doing. They provide very good care, but they're not able to give that same amount of love, kiss, developmental stimulation and training and care that you give your kid, your own kid, or another child that you're caring for. So we've looked at making a new eligibility definition. It is in our waiver, and it is also in the targeted service management. So there's supports coordination kind of service for these kiddos as well, even if they don't qualify for the waiver. So I can also provide that to Judy. It's again in the waiver, but we've got easier kind of cheat sheets on it here and there that I can dig out. But really what it is, it's a 0 to 21. It's a kiddo that's dependent upon technology and nursing. And there's 3 areas of adaptive deficit. That's, kind of a standard with the feds for what they see. It allows families to be able to support kiddos in that smaller family-like environment and to be supported by us. It does not require a diagnosis of intellectual disability or autism. So this is a new eligibility category. Really an important stride. Yeah?
Let's just say, is that above and beyond like what insurance would cover?
So they're different services. So yes, I think that's a yes. So the services that are written into the waiver are different than what's provided under the state plan if you're using medical assistance or a third-party private insurer. So it's looking at waiver services. So you're not talking about doctor's appointments now. You're talking about respite. You're talking about the medical support assistant, family medical support assistant. You're talking about those services that exist in the waiver. Additionally, this also opens the door for life sharing provided by families and compensation then, of course, as a life sharing provider. And there is an enhanced rate for life sharing through families. We just came back from our Everyday Lives conference, and if you ever have an opportunity to participate in that, I strongly encourage you because it's like a hotbed of ideas. And this year was one of the most exciting sessions that I attended was on the medically complex children. I have to stop calling them kids, but children. and a mom who, after her child being 6 years in an institutionally kind of setting, a facility, anything big to me tastes a little like big. She's able to bring Deacon home, and he hasn't been hospitalized. I think one of the big things for her is when he was facility-based, he was hospitalized with some frequency, and he hadn't been hospitalized in years, one of the things that she shared with us. She has nursing, she's doing life sharing. But the thing that really hit me hard, and I always get hit hard by at least one or two things, despite how long I've been doing this, is Mom described how at one point in time, before Deacon came home, before she was able to do life sharing, that he had to go to the hospital and she couldn't go because she was still working and supporting her 2 other kids. So she couldn't go with him, and that she could just see the look on Deacon's face was like, you're not coming with me. And she had said she'd go with him to the hospital, whatever. And she said that was one of the things that life sharing has done for her, is that she doesn't have to work outside the home. She's got her little guy home, and she doesn't ever have to let him go to the hospital alone. So it was just kind of like, I never thought of it in those terms. Like it's not the life I've lived. I didn't ever have to make those choices. And for her to just articulate it that way, that I never have to see that look on Deacon's face again, because I can go with him. And the reason I can go with him is I have this support. Yeah.
Can you explain how the mom is using life sharing?
So Mom is paid to stay home and really be his primary caregiver, but because of the level of need he has, she has nursing still through EPSDT. Kiddos are still eligible for all of the other state plan services. So she's there with him like a stay-at-home mom. I think a lot of us would have liked that. So she gets to be a stay-at-home mom. She has all the support she needs. She has some financial support through the stipend, so that that allows her to be at home with him, focus on him, and do all the other things that she needs to do. And additionally, she's got the support of a life-sharing agency. So when we do life-sharing with families, we still want them connected with agencies so that they've got that support. Right? So that just really kicked it in for me. And now I can remember some of the guys that I worked with. Nick is one of them. And Nick was someone who, if you put him on a test or something, you'd say he was pretty severely impacted. But the amount of social skills that he had, because he lived at home with his family until he had to be placed outside the home. And compared to somebody else that I might have worked with that could have the same profile, was just phenomenal. I mean, you just see the difference between how people spend their formative years, like how they learn to develop those relationships, how they're just, stimulated neurologically. We know, that the stimulation that you're going to get just picking somebody up and smooching on them. I was surprised my daughter had any hair left by the time I finished smooching on her. So all of those things are just some of the really big gains we expect to see as we see, this eligibility added to our waiver. And I can tell you there's so much interest from the facilities. Children's Hospital is calling us all the time. They're really working this with families to be able to get in, get early, get engaged, and start bringing the life course kinds of things into people's lives early on, as opposed to so many folks, we in ODP didn't catch up till after you graduated from school. Like, we just weren't engaged until that point. So this is really an exciting kind of development for us in terms of supporting families. And then additionally, when we look at our focus on children and families, you'll see that we are working on enterprise case management, which is like an IT system that, everybody goes, ooh, yuck. We're working on developing a new individual plan within our IT system that operates almost like one of your medical profile things, where you can just go in And you can access information, and you can add information, and you can see information, and it doesn't look like an ISP. So I can tell you that the Hixus ISP in 2002, when we developed it, was a blank document that we were all very excited about because it looked nothing like the Pennhurst individual habilitation plan that had preceded it. And it's turned into really heavy. Really heavy. It's also turned into a historical document, everything you ever wanted to know about somebody that wasn't any value to you document. You didn't hear me say that out loud. But not something that you can look at and say, okay, here's what Michelle wants to do this year, and here's the support she needs, and here's how they need to develop. And that's what we're looking at now. So we're looking at always having the ability to have that historical information, but get it, more in the background through links, and that the actual document that we'll be using for folks and their families and providers and us as well is going to be very much developed as a just like one of those portals. That's the word, a portal that people are used to and they can use on. So we're pretty excited about that. And of course, we're continuing to develop our life course principles, which we have Kathy Trainey in our office, who's an ambassador. Nancy Hampson also is in our office here in Pittsburgh, who's an ambassador. And life course principles, really, you'd have to have a whole presentation on it, and I'm happy to arrange it if you want either one of them, where you're, really starting out and going through the entire lifespan of a person and taking a look at, what should be happening now, what should we plan for later, what does everybody see? So a lot of it is the trajectory, where do we see people going, what's the vision? And just really keeps things focused and making sure that we continually focus on person-centered practices, what is it the person wants, and of course, what is it the family also wants.
Can anyone do life course work even if they don't have a waiver?
Sure. Yeah, people do. Sure. We've worked with, we've tried to get in the schools as well. But yeah, life course, we've done it for ourselves as an office at different points in time, looking at the life course principles, because really it just says, you really start out with what are the skills you have, what are the resources you have, not just, governmental or anything. What do you do yourself? So for me, now I'm getting to be good at computers. 2 years ago, I would have said no. So, my trajectory when we went to telework, 100% telework, was going to be learn how to use my computer and, not cry. So I'm kind of there. I know how to use Teams now. I learned how to share a screen. It was really remarkable. If you talk to the people that I work with, they'd go, yeah, we just can't even believe the old girl can do that. So, the life course just says, where are you? Where do you want to be? What are all the things that you have to help you get there? What do you need to get you there? And, how do you want to approach it? So, yeah, life course is for everybody and anyone. Strongly encouraged.
And if you don't have a waiver, it looks at natural supports and other things that you could probably build around.
Absolutely. A lot of folks don't necessarily even realize the supports that they might have or the skills that they might have. And you use it. And I hate to, Judy's better at this because Judy's done more work with it. So I am not the best person, like I said. I could get Kathy or Nancy here and they'll talk to you. Yeah, they'll love it. They'll love it. But you really do start from a place of what skills do I have, what supports do I need, and how can I get them? And it could be, are they available in the community? Is it school? Is it,
Dream of a good life.
Yeah, it is. It really is a dream of a good life. What is it that you see for yourself? And then kind of approaching it. And what's nice about it is it really breaks things out into ages. Which, I don't know that we always did very well. I think we just always just approached a person with a disability and didn't really pay as much attention to different stages of life. Probably because when we were developing all this stuff, we were all in the same stage of life. Everybody in the field is probably somewhere at this point between 55 and 70. So, we were a small group. It's really, we should schedule that.
Yeah.
I got a bunch of stuff in the office too we can use. The other thing that I wanted to talk a little bit about is our focus on quality and performance-based contracting. So you will hear more about this, but we've looked at and you've looked at some of the residential services available and found them wanting, I think is probably fair. We've looked at it and said it's not necessarily producing the independence that we thought it would produce. It's really kind of just generating more residential programs. And are they all good? And are they all equal? And are they all doing what they need to do? And are they meeting people's needs? And the answer to that is largely yes. Largely yes. Vast majority of folks are satisfied. Vast majority of providers do a good job. Could they do better? And are they moving people on to further independence? So the answer is yes and no. They could do better, and no, they're not moving people on to further independence. So we want to encourage that. And one of the things that we are exploring, so we're exploring it, is performance-based contracting. And right now, the way that it works for you to become a residential provider in ODP is you have to, take some classes, pass some courses. You have to meet certain criteria in terms of your financial stability and your structure and your experience. And then you have to get licensed, and you're a residential provider, and everybody's equal. It's all available and willing providers. We'd like to move the bar. So we'd like to talk about acuity level. So some folks need a lot more support than other folks. So we'd like to talk about acuity level in a different way. Right now, we talk about it only through rates. We'd like to talk about it through rates and through qualifications and skills and experience. And we'd like to talk about the services that you offer, because we know we need to develop services. We don't have enough qualified service providers. Some folks kind of get in a niche, and maybe they could be offering something more. So do you offer like a continuum of services so that people can learn and grow if they choose to do something different? And do you have accredited workers? So we've put a whole lot of focus on making sure that staff are well-trained, well-supported, and working towards credentialing. So there's different organizations in the states that offer credentialing for their staff, for DSPs. And we'd like to do that, and we'd like to do it as a professional development. So, I talk about I started as a DSP, and 13 of the full-time people in the 14-bed little house I worked in, 11 of us had our degrees or were a year away from our degree. And we were in it as a profession. This is where we were going, where we're starting. We don't see that as much. And we may not see as many degreed people because we don't have the same, it's not as new as it was in 1980, so the world was just beginning. But what we do know is that if we take a look at compensation, which we are, and if we take a look at professional qualifications, that's a different workforce. So it's a whole different workforce. It's a whole different thing to say, I have this credential, and I can take it with me. So if I'm applying for a job someplace else, I can take this credential with me, and professionalizes the work that's being done by direct support professionals, and as it should be. Yeah.
So do you see that heading towards people who hire their own staff in their home, or just in the residential arena, this whole credentialing?
At this point in time, we are only talking about ResHab.
Okay.
We're only talking about ResHab. And I think there's so many distinctions between when a family is providing the oversight as opposed to if a provider is providing the oversight, that we'll always be taking a little bit of a different look at those things. But this is provider-based. We're only looking at residential habilitation. So that's what folks would think of as community homes. Yeah.
So is there an effort on the other side to increase rates if, you're trying to work with a more professionalized staff? Obviously, you have to pay them more.
So
How do you do
we could
that?
have the rate discussion, but I wouldn't be good at it. Yes. Eventually looking at then, right now if you look at our rates, they're acuity based, so the level of need of care. And, the more care that you need, the higher our residential rate is. So yes, we would be looking at this, but the other thing about performance-based contracting is you've got to demonstrate that you can provide that high level of care before you provide it. And right now, you just have to be qualified. So you just have to have done all of the things you need to do, but you could have never served a person in residential and still be at the highest acuity based on the person. Whereas as we move into this exploring, and we are exploring, so it's not everything, and it will be coming out for public comment and everything else, but it's out there, we're talking about it. It's not just based on my needs, it's based on your skills. So, you've got to demonstrate some stuff. Part of it would be credentialing your staff. Also, it would be, how much clinical availability. There's a number of different kind of performance measures that we are exploring. We're exploring them with our strategic thinking committees. So we have a residential strategic thinking committee that has a lot of representation from our community on it to help us think about what we're doing moving forward. We've explored this with our providers, and you can well imagine there's different feelings. And we've explored this with our ISAC, our Information Sharing Advisory Committee, and that is a committee that advises the Deputy Secretary, and it's comprised of self-advocates, family advocates, advocacy organizations, provider organizations. I'm sure I'll be missing somebody, the deputy, a couple members of our staff, not too many, and they provide advice and determine stuff. Yeah.
Do you have any thoughts about providers that are deemed to be for-profit versus nonprofit providers? Is that a distinction that is being included, or how do you
I can't recall any discussion of that. And I can't say as I know the difference when I'm working day-to-day with providers. I'm often surprised at who's for-profit and who's not for-profit. So I don't know that it's, I'm sure at some level there's a difference, but I think it's probably more on the people operating the agency than it is on the status of profit or nonprofit. Because honestly, I couldn't, we've got probably close to 300 providers. I couldn't tell you who's profit and who's nonprofit. And as I said, I'm often surprised, and I'll go, really? How about that? But it's not a consideration. So the waiver doesn't care. Licensing doesn't care. Licensing doesn't care about money at all. Licensing is totally blind to who's funding you. Licensing is about the licensing rules. So it's really juggling everything together. But anyway, this is really exciting to be looking at not any available willing provider, but to really start developing that skill within these ResHab providers. So that's part of our focus on quality. Also, I mentioned ISAC. If you've never seen the Everyday Lives document, I should have gotten a handful on my way here, but I could certainly make sure you have some. But within our Everyday Lives document, since 1991, we've been publishing the document and doing the conference, and there have always been focus areas of things that we need to do better at. And in about 2013, 14, 15, we really expanded on that quite a bit to look at recommendations for improvement, and held a lot of meetings with stakeholders and developed that. And there's about 14 strategies or recommendations for improvement within the Everyday Lives document that were brought forward. They're ISAC recommendations that are part of what we work on. Everything we do as we report out quality, we have to tie back into the ISAC recommendations. So continued work on those has been part of our focus on quality, taking another look with the ISAC group. Are these still the things we want to work at, and are we approaching them the way we should? So that has been going on. And then just in general, we've been looking at enhanced provider qualifications. So one of the things that I talk about a lot, I think, is ResHab, because it's just something that you just always got to keep your eye on. It's people. And one of the things that we've added into the provider qualification for residential as of January is now you have to have provided supports to individuals with intellectual disability or autism for 2 years in some other capacity before becoming a residential provider. because, it's not something anybody can do. And I'll say that one publicly. It's just not something anybody should do.
So could you talk about that? What does that mean?
It means that, so I think, as I said, in the past, you just had to take the class, pass the class,
Yeah.
get licensed, blah, blah, blah. Now, in all of that plus, you have to have successfully delivered services to people with intellectual disability and autism, whether
Like a
it's
day program?
home and community hub, whether it's community participation supports, employment, but you have to have a combination of successfully delivering those services. So that's been added as of January 1st, and that, believe me, is providing a little bit of angst within the newer provider community, because they're like, wait a minute, what do you mean? And we're kind of like,
Oh, you added the word successful. So-
well, that's probably me. You can't have lost your provider agreement. You can't have been kicked out. So stay tuned. More on that. And then, I mean, really, those are our major focuses this year. We are trying to look at how can we get some assistance into individuals' hands around rent. If you listen to the news at all, our community news, the Department of Human Services is looking at, and I'll just do some numbers, don't try to keep them in your head, it's taken me 40 years, but an 1115C waiver, which is a demonstration waiver. And the department is looking at a demonstration waiver, which will allow us to use some money from CMS for things like housing, to help with housing. It's short term, to help with food security, which is something that a lot of people face, is food insecurity, particularly in the DHS system as a whole. Certainly within our community, of course, as well, since we're, spread across. So that's some pretty exciting kind of steps that we're continuing to take towards towards just raising people up and creating their ability to be independent and living in the community, and how do we support and how do we look outside of the box a little bit. So stay tuned on that one. Other upcoming things are, you may notice it, there's a new supports intensity scale this year. It's just a new version. Anytime there's a standardized assessment, it gets updated with some frequency. Anything you've ever looked at, your kids' performance testing in schools and stuff like that, they upgrade it. You'll see another edition. Same thing with this.
Michelle? Who has to do that scale?
The sports intensity scale. Everybody in the waiver, every 5 years. We also use it for recertification and going into the waiver.
Gotcha.
And then within our rates, because I know y'all showed me some rates, you were looking at residential, there's a new needs group 5. Yours is only going to show up to needs group 4. There's a new needs group 5. So that is another higher level of acuity of care, increasing the rate. What we discovered with needs groups 1 through 4 was that there are folks who need support above and beyond what that provides, what that rate provides. So we've looked at those individually, by person. What is it that you need in terms of staffing or clinical support or stuff like that? And it's all related to staffing, clinical support, training. And we had a whole lot of individual rates, and a whole lot of individual rates is really hard for everybody. For the department, certainly, for fiscal, for families to take a look at and understand where they are, for providers to try and manage. So did a lot of statistical algorithmic analysis by our finance bureau director, Rick Smith, to discover that 90% of those, something like 5,000 individual rates, all fall within this range. And we could add a category. So less labor intensive on everybody. If you meet that criteria, you can move into that rate, as opposed to having to have at least 4 or 5 people review it from a bunch of different aspects and fill out all kinds of different financial instruments to be able to do it. There still will be a process for exceptional rates, a little bit different, but we anticipate much less. The reason we have to do that is we have a fee schedule, and so if you pay outside the fee schedule, you have to have a process to tell CMS why you might do something as crazy as pay outside the fee schedule. and that was ours, the needs exception rate. And then the other thing that we're focusing on right now and, help us get the word out is during the pandemic related to medical assistance, the recertification was kind of just kept on. And there are a number of people who are at risk of losing their medical assistance. And, that creates all kinds of other kind of danger zones for them related to their benefits, related to waiver as well. So what we have been doing, the department has been getting, by department I mean DHS, Department of Human Services, Office of Developmental Programs is part of that, has been getting us lists out monthly of people that are, hitting up against that date, or, unfortunately some had hit past it when they started. So we're working on that across all of the 4 regions. We're getting those lists out, we're getting them to the county programs and to the SCs to try and reach out and support families to make sure they're not going to lose their benefits. So super important. If I can do a pitch for any of you, family, friends, anyone else, that needs any help, please touch base with an SC, with the CAO if you're not engaged in our services, but really pay attention to that medical assistance recertification coming back up, because holy cow, that is the trigger for a whole lot of things. So I think that's what's new. The rest is we just keep on keeping on. But in terms of the newer stuff that we're focusing on, that's where we are. Any questions on any of that? I know it's a lot fast. Yeah.
Question. You mentioned the new eligibility criteria for medically complex children and how that opens the door to life share. And you mentioned that one example, the family that you talked about.
Mm-hmm.
How does ODP envision, there's a lot of families that are getting really attracted to the life share option for their own children.
Mm-hmm.
What about when you can't do it anymore?
As a family.
Yeah. I mean, there's a lot of aging caregivers out there. I'm one of them. And I have a very complex kid, very profoundly impacted with behaviors, significant behaviors, very difficult to find any services, providers, day programs, anything that really wants to take him. And, within the network of families that I connect with around the state, actually, we're kind of all in the same boat, where we have loved ones that have actually tried out group homes, got kicked out of group homes because their support needs were too high. So life share seems like a great option until you can't do it anymore.
Right. I think, and I'll slither back in to life course, because that's part of the kind of trajectory that you might be exploring, and what would you do next? I think that if as a family you're not able, and there has to be a point where you're not able, I mean, come on. We do get that. We're just trying to figure out how to make it happen the way folks want and need it to happen. You are going to be planning into other kinds of services, whether you're moving to residential, whether another family member or a recruited family might want to be part of the person's life and offer those supports. But, that's kind of where we are.
That's a real hard sell for a lot of parents to say, I'm going to pass this baton to my, the sibling of my really compromised child. It's not an option for me. I won't do it to my daughter.
Yeah.
Would you go to another family? Would you allow another family to care for your child?
No. I mean, my husband and I went to a family wedding in July. We were gone for 4 hours. We had to really, bribe, not really bribe, but we had to really, talk a couple of family members into coming and staying. And that's the first time we'd gone anywhere together in 4 years.
Yeah.
Anywhere. So this is a reality for a lot of families. And I guess the thing that worries me, I've read a lot about the performance-based contracting, read the concept paper, I've seen some of the stuff that Strategic Thinking Group, I guess they're calling it, is put out. And I think people in our space who already feel like we're pushed out to the margins, concerned that we're going to get pushed out even further. Because I would imagine that this model is going to, obviously, it's going to reduce the number of people doing some of these residential services, correct?
I don't believe so.
Wouldn't you be incentivized as a provider to go out of business if you couldn't meet that higher bar? I mean, some of them are struggling financially as it is now.
So we're not getting that sense at all. And part of the consideration as we're moving through this is smaller providers, and how will it work for them. No, I don't anticipate less, actually. I think that I hope that a couple things will happen. Right now, there are, as we're looking at it and as it might enhance rates and enhance your ability to do stuff and provide, that additional financial resource, that there are some providers who may do more. So there are some providers who may not feel like they can expand, or that they, don't have the resources or the ability to attract staff or stuff. So by professionalizing the staff, by offering incentives around staff, by, looking at this kind of training and credentialing and stuff, we're hoping to enhance the labor force and get people to stay in as a career. I mean, that is as critical as anything else that we're doing, is taking a look at the workforce, professionalizing it, and finding, ways for people to stay in. And there's a couple things we know about the workforce. We know it's real different from 40 years ago in everything. We know that we are at just a critical point for caregivers, right? Across the board. I'm 65, I may need a caregiver, hopefully in a while, but, I will be in that group. And so there's a lot of competition too for caregivers. So then, what is it going to make somebody pick our community? And is it that, level of professionalism? Certainly the rate of pay. Is it the training? Is it the, kind of flexibility of credentialing and stuff? But really taking a look at what is it that this current workforce is interested in, and how do we encourage them to stay, and what does that look like? And providers have tried different things over the years, different levels, lead staff, stuff like that. And Dr. Amy Hewitt, and now I won't remember where she's working out of, has just presented at our conference, but just done just a boatload of work around the workforce. And it's not just the money. The money is big. You got to have a living wage. And I can testify, working in government all these years, it's not just the money. It's definitely not just the money. So it's also a choice of the work that you want to do. So how do we make this work that people want to do? Well, we've got to make sure they understand the value, that they really understand the value, and that you change people's lives by what you do when you spend time, and your life will get changed, and it'll get changed for the better. How do we get that message across? And that's part of what we're looking at, and a huge part of some of the credentialing programs.
I have a very specific question and situation. We've been working for 3 years to try to figure out how can our son live more independently away from us. And we have like 5 different entities in our house. We have two nursing agencies, 1 HAB agency, and then we have self-directed.
Mm-hmm.
What we've discovered in trying to build a team in the home is that the thing that is the most difficult is his feeding tube. His feeding tube drives the whole day. Like you'd think it wouldn't be, but he does a lot of stuff. But somebody's going to be on top of that feeding tube because, it does different things. He gets medicine through it, and then he gets something else, and then you have to take it off because he's going to have exercise and put it back on. You have to recalculate. And when, in the past, when it was just my husband and I doing it, that was fine. We were on top of it. Now we have a lot of different caregivers coming in. And what we find is that when you have nursing, we have probably about 40 hours of nursing a week. When it's a nurse, it's great. They're on top of it. They can handle feeding tubes. And I should say that he doesn't have a feeding tube just because of the CP. I mean, it is, but he has a complete complex digestive system that it's not just putting the food in. When we have nurses, we don't have to think about anything. They're on top of it. But when we have habilitation aides, if we have a companion, sometimes they're not even allowed to touch the feeding tube. Some agencies, I don't know if it's state law or whatever, they're like, they are not to give medicine, they are not to do anything with that feeding tube. They can't even turn it off. They're not even allowed to turn it off if it's beeping. That's it. They're not allowed to touch it. So we have a significant amount of habilitation hours where they're not allowed to touch his feeding tube. So essentially, they're there, and also the parent has to be there too to manage the feeding tube. And companion, that's,
Yeah,
totally out
companion
of the
is-
question that that person would have anything to do with the
Mhm.
feeding tube. So what I've been, because it's going to take us probably another couple years to figure out his move to where would he go, what is that more independent living, supported but more independent living away from the family, what would that look like? It's going to take us another couple of years. So right now, we're saying we're stuck because we see that we can never be away from home unless there's a nurse here, because always there has to be one of the parents there.
Because of the feeding tube.
So I'm like you, we haven't gone on vacation in like 20 years. So anyway, it's not just vacation, it's going to a wedding.
Going to the doctor.
Going somewhere. We cannot both be gone. One of us always has to be there. And really, after 28 years, you're like, I'm kind of tired of having to be here every moment. Like, even if the system allows for all the support and caregiving, but it can't do all of it, so we still have to be here. So my question I've been floating, and I did this at the ISP meeting, and is, can my son have nursing 24 hours a day? Because the companion is not working. It's not addressing his medical need. So I've been told in very plain terms, I had a representative from Allegheny County DHS at the ISP meeting who told us he is not allowed to have 24-hour nursing in his private home because the principle there is if he needs 24-hour nursing, he should not be in the private home. He should be in a facility where he can have, that's the reasoning. But that goes against his everyday lives. He wants to be independent. He doesn't want to be in a facility. But he's probably a CIS-5 that he has a high level of complexity. So I am on a battle right now to get an understanding of why he cannot have 24-hour nursing.
Let me look at it. So discrete nursing is not intended to be a 24-hour service. I'm not sure that's exactly the rationale behind it, but let me not misspeak. The other option is, has anyone ever looked at enhanced?
We have enhanced habilitation.
Can that be 24/7?
Yeah, I have a problem with it.
Well, they can't find anybody
That's
to
the
do
bigger
it,
problem.
but
That's the bigger
it's in
problem.
the ISP.
Yeah. That's the bigger
I know
problem.
that there's a category for
That's
it.
interesting, we should follow up with, I'm interested
Yeah.
in that too. Not all of us
I
have
wrote
that
it
level
down.
of complexity, but that is something. I'm going to wrap up this conversation with a question for you, Michelle. You
Okay.
heard about all these families and all of our journeys, and a lot of them are have older kids. My son's 33, 28, various ages. What is and you talked a lot about ODP's family and children. What can ODP do for our families, and how do we inform ODP about the needs of our families? I know the everyday lives is one way, right? Because I don't think everybody's taking advantage of that and understands it. But I'd be just curious on how do we connect in and make our needs known and try to affect some change, because there's a lot of good things happening, and it's apparent ODP can change, the government can change, all the things you talked about.
We could do it.
So, right? But it takes a while sometimes.
Takes a while. Even if we
Yeah.
wanted to do it tomorrow, it's got to go through a lot of approvals and
Yeah.
stuff, but we can do it. I think that the advocacy groups communicate a lot. I think that Achieva out here, I mean, Nancy Murray and whoever, she's got some people
Yeah, and Mary Harley's stepping in, so she'll be.
very good. I think that continuing to, invite us out so that we can hear where we need to do better. And, we bring it back. We really do bring it back. And I think in the moment, it's hard to affect change with government. I will admit that. Like in the moment, it's hard to affect change with government. But I think, letting us know when things are going wonky, and letting us see if we can find solutions to things. I think life sharing is really a place that I've long wanted to see developed. I've been involved in life sharing. I think I was the lead for a while in the Northeast. And life sharing with a recruited family. And that's like kind of a hard thing, because, if I can't do it, how could this recruited family do it? But I think it's like a better group home kind of concept. When you look at it, a lot of the things that are worrisome about a community home are the staff turnover. Somebody different all the time. That doesn't happen in life sharing. So even if it's a recruited family, you've got a lot more consistency in the people that are providing care. So I think it's an option that we need to continue to explore. I think the stuff that y'all are doing, looking at, people moving into their own homes, I can tell you that the idea of, 15,000 one-person homes it's not going to be supportable. It's just not going to be supportable. Really just kind of tough to do. There's other kinds of, one of the things I like about life course, so I'll always throw life course back in, is life sharing can also look different at different stages in people's lives. So I've seen life sharing kind of with a college roommate. And then that evolves into something else at another time. So it may not, life sharing with a recruited family is never going to be your natural family. Like it's not going to be. But it's still that more typical life that the rest of us experience. And as we move more and more into, credentialing and making sure that supports are out there, we actually have really good outcomes in life sharing, by the way. We've had life sharing families that stuck together 40-some years. And it's probably an easier transition. Folks that move into community homes, it's a hard transition, just so you know. For me as a person, it's a hard transition because things are different. There's rules. The government, so through licensing, has an obligation to ensure safety. One of the ways that we do that is regulations, and they can be hard sometimes. They can be tough to work with. So I think exploring life sharing. I think continuing to look at new models. So if anybody had ever said to me we'd do life sharing in a natural family, I would have said, that sounds great, but really? Like, how are we going to do that? But we did it. We're not a developmental disability state, but we got these medically complex kids. So, that came out of a need that arose, that families brought to us, that we saw. We licensed some of these facilities, and the vast majority do a really nice clinical job, but it's not a family. It's not the way a kid should grow up. And just really strong advocacy. You see the family medical support. I'm telling you, when you read it, you're going to see your job description. And that got it right into Nancy Thaler's hands, who was our deputy secretary at the time.
So when you were talking about how different people will need caregiving at different points of life, I'm thinking about when my grandmother had dementia. She ended up moving to Oregon, which is where my aunt lived. And Oregon is maybe a little bit more, they have like one of the lowest rates of elderly people in nursing homes, whereas Pennsylvania is one of the highest. And
Yeah.
so they're a little bit more
Oregon's done some cool stuff.
cutting edge, maybe, or on the, and so she actually lived in a, so it sounds like life sharing, there were people who lived in normal houses, like on normal streets,
Mm-hmm.
but they would have like 4 elderly people living with them. And So my grandmother lived in like a normal house and had her own bedroom, and it had like a quilt that looked like something, you know, it
Yeah.
felt like a normal home as
Yeah.
opposed to like a nursing home.
Yep.
So is that part of the vision of life sharing, that you might have a couple of, like, I think with my daughter, I can't imagine her living by herself, because that would, A, be tough for her, but B, it also seems lonely. My sort of dream is like, like when you talked about sort of college, like when I was in college, I lived with a bunch of friends, and we had like a chore wheel, and we had like different people cooked every night. And,
Mm-hmm. We did too.
you know, I
They're my
sort of-
travel buddies now.
Yeah, so I could picture Sarah living in a house with like a den mother kind of person. You know, Sarah does still see a million clinicians, but she's not in the same kind of medically
Mhm.
fragile state as some
Mhm.
other folks' kids. But is that at all a model that might be pursued of sort of, maybe that's just a group home? I don't know, but
No, it's kind of a life sharing. We limit it to 2 because you start getting bigger, you start looking more, you know, like a group home. But that's life sharing. And that's kind of, it's as much or as little as you want it to be in terms of engaged in the family's activity. So we have folks who live with a life sharer and have kind of their own thing and do some family stuff. We have other folks who live with a life sharer that just completely function as part of the family. And, you know, no real distinction. And we have a lot of people who do life sharing, you know, somewhere in the middle. And a lot of those relationships last a long time, but a lot of those relationships also switch. But again, you're dealing with one primary caregiver, you know, and not, I think you need 8, maybe at least 8 to do a 24/7 full-time equivalence kind of people. So, and certainly the turnover is much less, but that's exactly what life sharing really is. And you can do it you can do it in your own home. You can do life sharing. You can do life sharing. You can do it in, you know, a recruited family's home. I can be the person receiving supports and invite Judy to live with me, and she can be my life share caregiver, but she's living in my house. So there's a lot of different ways to approach the life sharing model. All of them involve an agency, just because we don't want folks just stuck out there on their own trying to figure it out. So that was one thing that when we talked about moving to life sharing with families, or all the different ways that we could conceive of it, we were all like super clear we want, and families super clear who participated in the conversations. No, we want this licensed where it's appropriate, because there's rules, as Tina found out, about what you can and can't license. I can't just go out and say, I'm going to license that one. And then additionally, that support of the life-sharing agency, because you have a life-sharing specialist who's in there helping you make sure you do stuff. You know, you're in a crisis, you've got that agency as a backup for you. So, yeah, that is the vision. You articulated it better than me.
So is there any vision for which there is a private pay model for this? So Sarah she's not, I mean,
How do you qualify for life share? I
so
guess
she
is
has
really the
100,
question.
her IQ is like 100. You know, she has her processing speed is in the single digits.
Yeah.
So she is not going to be able to, on her own, like,
Right.
pay her utility bills and like
Right.
grocery shop and like.
We've all got different
adulting.
skills. Yeah, we've all got
Like,
different skills.
That's a little
Um,
above and beyond. but-
So I'll just say straight out, I work in intellectual disability autism, and those are the eligibility criteria for our life sharing. Are there other models? I'll ask around. I don't know what Community Health Choices offers. Their waiver is really rich. Our provider network needs enhancement. Theirs really does. And I think their rates of pay might be a little less. That's kind of making things difficult. But I'll ask around to see what other models I know aging, there seems to be this kind of a model almost everywhere. Aging has a domiciliary care model, which is also kind of what you were talking about, but that's, I think it's 3 people in a home living with a family. So there are different models. I'll ask around.
I think I need to wrap up with Michelle. Anybody last questions? Okay, thank
So
you.
I
Oh, go
have a
ahead.
last
Yeah,
question.
yeah.
You mentioned something about working with smaller agencies, and I'm really curious about that.
So working with smaller agencies, ResHab.
Yeah.
So, so some of the things under discussion for performance-based contracting, and I mean, there is a lot of information out there on it, are offering a continuum of services. So as I said, people get stuck in ResHab, residential habilitation, sorry, which is what folks think of as a community home, for a really long time that might not need to be stuck there. And some of it is economics. And that's something we're really trying to figure out, how we can get money in the hands of people to pay their own rent as opposed to, being stuck economically in a group home. Some of it is comfort. Somebody's been in a community home for a really long time and can't really envision something different. And so we're talking about that as part of what we want to see is the ability of providers to offer folks these options, not to be. Some of it's going to be based on, how much clinical time you have available in terms of acuity, and that might be the medical, it might be the, some folks struggle behaviorally or with mental health. And so there's some smaller providers who do, I think, what everybody would think of as a traditional group home. Some staff to make sure you do your shower, they make sure you get your meals, you get to your appointments and stuff. And they do it well, and people are really happy, and they want to stay there, and they're a little bit worried about how do we incorporate all the rest of this stuff. So, that's part of a consideration too, is how do we support that? And there are also some, smaller agencies that serve very few people, but very specific niche, So, taking a look at all of that, soliciting comments on all of that, and how does it look. That said, we got to have expectations. Not having expectations really can lead you into poor quality, and we got to have expectations. So it will be an opportunity for some of the smaller agencies to up their game. We'll look at the considerations around others, but initially, the concept is nobody gets thrown out. They have the opportunity to come up to expectations. So that's kind of the initial thing. But yeah, we have providers who might support over 300 people. We might have providers who support 8 or 10. And you could have great quality in both, and you could have not so great quality in both. The not so great quality are the ones that I lose sleep over. So I'm excited about having this kind of expectation being brought in. Like available willing provider sounds nice at first, but in reality, it could be enhanced.
Thank you.
Mm-hmm.
Thank you so
Yeah.
much for being here.
Sure.
And I'm going to say we'll wrap up that part.